Mastering the genitourinary and renal systems is not merely an academic exercise for the family nurse practitioner board examination. It is a fundamental requirement for safe and effective primary care. These systems are intricately linked to cardiovascular health, metabolic function, and overall patient well-being, making their assessment and management a daily reality in clinical practice. Conditions ranging from the seemingly simple urinary tract infection to the complex presentation of acute kidney injury demand astute diagnostic skills and a firm grasp of evidence-based guidelines. A failure to recognize subtle signs or initiate appropriate first-line therapy can lead to significant morbidity, including sepsis, chronic kidney disease, and permanent organ damage. Therefore, your ability to confidently navigate this content will be directly reflected in both your exam success and your future clinical competence. The FNP certification exam is designed to test your capacity to function as a competent entry-level provider. This means you must demonstrate proficiency in identifying common presentations, ordering the correct diagnostic tests, interpreting the results, and formulating a safe management plan. Genitourinary and renal questions will test your knowledge across the lifespan, from pediatric enuresis to prostatic hypertrophy in older men and incontinence in postmenopausal women. The scope is broad and the stakes are high. This review will systematically break down high-yield topics, providing you with the structured knowledge needed to analyze case scenarios and select the single best answer. We will focus on the essential elements: risk factors, clinical presentation, key diagnostics, and first-line treatments for the most frequently encountered disorders in a primary care setting. This comprehensive guide is structured to build your confidence by reinforcing core concepts one condition at a time. Think of it as building a clinical scaffold. Each piece of information about a specific disorder adds to a stronger, more integrated understanding of the entire system. We will explore the nuances that differentiate a simple cystitis from a life-threatening pyelonephritis and distinguish between the various types of urinary incontinence, each requiring a unique therapeutic approach. By focusing on these distinctions, you will be better prepared for exam questions that require you to make critical clinical judgments. Remember, the goal is not just to memorize facts, but to understand the pathophysiology and clinical reasoning behind each step of the patient care process. Success on your board examination hinges on your ability to apply knowledge, not just recall it. Therefore, as we proceed through each section, actively engage with the material. Consider how a patient with these symptoms would present in your clinic. What questions would you ask? What physical exam maneuvers would you perform? What red flags would you be looking for? This active learning approach, combined with the detailed information provided here, will transform your study sessions from passive review into active clinical problem solving. Let us begin this essential review to ensure you are fully prepared to demonstrate your expertise and earn your FNP certification. Acute kidney injury, or AKI, represents a sudden decline in renal function, leading to the accumulation of nitrogenous waste products and dysregulation of fluid and electrolytes. As an FNP, you must be able to identify its causes, which are categorized as pre-renal, intrinsic, or post-renal. Pre-renal AKI, the most common type seen in primary care, results from decreased renal perfusion. Key risk factors include hypovolemia from dehydration, hemorrhage, heart failure, sepsis, and the use of medications like NSAIDs or ACE inhibitors in at-risk individuals. Intrinsic AKI involves direct damage to the kidney tissue itself, often from nephrotoxic agents like aminoglycosides or contrast dye. Post-renal AKI is caused by an obstruction of urine outflow, such as from benign prostatic hyperplasia, kidney stones, or a blocked Foley catheter. The clinical presentation of AKI can be subtle and is often overshadowed by the underlying illness. Patients may report nonspecific symptoms such as fatigue, nausea, anorexia, or a reduced urine output, also known as oliguria, although a non-oliguric AKI is also common. In a pre-renal state, you might find signs of dehydration like tachycardia, hypotension, and dry mucous membranes. A physical exam should include assessing for flank pain, which could suggest an intrinsic or post-renal cause, and checking for a distended bladder, indicative of obstruction. A thorough medication review is absolutely critical, as many common drugs can precipitate or worsen renal injury. Always ask about recent imaging studies with contrast, new prescriptions, or over-the-counter NSAID use. Diagnostically, the hallmark of AKI is a rise in serum creatinine and a decrease in the glomerular filtration rate. An increase in serum creatinine by at least 0.3 milligrams per deciliter within 48 hours, or an increase to at least 1.5 times baseline is diagnostic. A urinalysis is a crucial first step. In pre-renal AKI, the urine will be concentrated with a high specific gravity and minimal sediment. In contrast, intrinsic AKI, specifically acute tubular necrosis, often presents with muddy brown casts. A renal ultrasound is essential to rule out hydronephrosis, which confirms a post-renal obstructive cause. Further tests like a fractional excretion of sodium can help differentiate pre-renal from intrinsic causes, though this is more common in inpatient settings. First-line treatment in the primary care setting is centered on identifying and reversing the underlying cause. For pre-renal AKI due to dehydration, the immediate intervention is aggressive fluid resuscitation with isotonic saline. Any potentially nephrotoxic medications, such as NSAIDs, ACE inhibitors, and ARBs, should be temporarily discontinued. If a post-renal obstruction like benign prostatic hyperplasia is suspected, prompt referral for bladder catheterization or to urology is necessary. Patients with signs of significant volume overload, severe electrolyte disturbances, especially hyperkalemia, or uremic symptoms, require immediate referral to the emergency department for potential nephrology consultation and dialysis. Your role is to stabilize, manage reversible factors, and escalate care appropriately. Acute pyelonephritis is a serious infection of the kidney parenchyma and renal pelvis, most often resulting from an ascending infection that originated in the lower urinary tract. The primary pathogen is overwhelmingly Escherichia coli. Key risk factors include a history of recurrent urinary tract infections, female sex due to a shorter urethra, pregnancy, vesicoureteral reflux in children, and any form of urinary tract obstruction like nephrolithiasis or benign prostatic hyperplasia. Other significant risks include uncontrolled diabetes mellitus, which impairs immune function and can cause neurogenic bladder, as well as recent urinary tract instrumentation or catheterization. Immunosuppression, whether from disease or medication, also increases a patient's susceptibility to this severe upper tract infection. The clinical presentation of acute pyelonephritis is typically more dramatic and systemic than that of a simple urinary tract infection. Patients present acutely ill with fever, chills, flank pain, and pronounced costovertebral angle tenderness on physical examination. Nausea and vomiting are also very common due to the systemic inflammatory response. These systemic symptoms are accompanied by classic lower urinary tract symptoms, including dysuria, frequency, and urgency. In older adults, the presentation can be atypical, manifesting as confusion, delirium, or functional decline without the hallmark fever or localized pain. This makes a high index of suspicion crucial in the geriatric population presenting with any acute change in mental status. The key diagnostic finding for acute pyelonephritis is a urinalysis that reveals pyuria, bacteriuria, and often white blood cell casts. The presence of white blood cell casts is pathognomonic for pyelonephritis, as these casts are formed within the renal tubules, indicating upper tract involvement. A urine culture and sensitivity must always be obtained to confirm the pathogen and guide antibiotic therapy, especially given rising resistance rates. A complete blood count will typically show leukocytosis with a left shift. For patients who are severely ill, toxic appearing, or fail to respond to initial therapy within 48 to 72 hours, a renal ultrasound or CT scan should be ordered to rule out complications like a renal abscess or an obstructing stone. Treatment decisions are based on the severity of the illness and local antibiotic resistance patterns. For a non-pregnant, hemodynamically stable adult who can tolerate oral intake, outpatient management is appropriate. The first-line treatment is a fluoroquinolone, such as ciprofloxacin or levofloxacin, for 5 to 7 days, but only if local Escherichia coli resistance rates are less than 10%. If resistance is higher, an initial one-time intravenous dose of a long-acting cephalosporin, like ceftriaxone, or an aminoglycoside is recommended, followed by an oral regimen based on culture results. Patients who are pregnant, vomiting, septic, or hemodynamically unstable require immediate hospitalization for intravenous hydration and parenteral antibiotics, typically ceftriaxone or piperacillin tazobactam. Nephrolithiasis, or the formation of kidney stones, is a common and intensely painful condition. The primary risk factor is chronic dehydration, which leads to supersaturation of urine with stone-forming salts. A personal or family history of kidney stones significantly increases an individual's risk. Dietary factors play a major role. High intake of sodium, animal protein, and oxalate-rich foods, like spinach, nuts, and tea, can promote the formation of calcium oxalate stones, which are the most common type. Certain medical conditions also predispose individuals to stones, including hyperparathyroidism, which leads to hypercalciuria, gout, which is associated with uric acid stones, and recurrent urinary tract infections, which can lead to struvite stones. Anatomical abnormalities of the urinary tract also increase risk. The classic clinical presentation of nephrolithiasis is the abrupt onset of severe colicky flank pain that often radiates to the groin, testicles, or labia as the stone migrates down the ureter. This pain is often described as one of the most severe pains a person can experience, causing patients to be restless and unable to find a comfortable position. Gross or microscopic hematuria is present in the vast majority of cases. Associated symptoms may include nausea, vomiting, dysuria, and urinary urgency. It is critical to rule out emergent conditions that can mimic this presentation, such as a ruptured abdominal aortic aneurysm, ectopic pregnancy, or pyelonephritis, especially if the patient has a concurrent fever. The diagnostic evaluation begins with a urinalysis, which will almost always show microscopic or gross hematuria. The urine pH can provide a clue to the stone type. A pH below 5.5 suggests a uric acid stone, while a pH above 7.2 suggests a struvite stone. However, the definitive imaging modality for diagnosing nephrolithiasis is a non-contrast helical CT scan of the abdomen and pelvis. This test has high sensitivity and specificity for detecting stones, identifying their location and size, and revealing any associated obstruction, such as hydronephrosis. A renal ultrasound is a suitable alternative for pregnant patients or those for whom radiation should be avoided, though it is less sensitive for small or ureteral stones. Management of nephrolithiasis is guided by stone size, location, and the presence of obstruction or infection. For small stones, less than 5 millimeters, that are likely to pass spontaneously, conservative management is the first-line approach. This includes aggressive hydration, effective pain control with NSAIDs like ketorolac or opioids if necessary, and medical expulsive therapy with an alpha blocker like tamsulosin to relax the ureter and facilitate stone passage. Patients should be instructed to strain their urine to catch the stone for analysis. Larger stones, greater than 10 millimeters, or stones of any size causing intractable pain, severe obstruction, or signs of infection require urgent urological consultation for interventions such as ureteroscopy or shockwave lithotripsy. Urinary tract infections, or UTIs, are honestly one of the most common bacterial infections we see in primary care, especially among women. The most significant risk factor is, well, simply being female because of the short urethra and how close it is to the anus. Sexual activity is a major precipitating factor, and that's often what leads to what we call honeymoon cystitis. Other risk factors include the use of spermicides, which can disrupt the normal vaginal flora, postmenopausal status, since estrogen deficiency can cause atrophic vaginitis, and incomplete bladder emptying from conditions like benign prostatic hyperplasia or neurogenic bladder. Indwelling catheters, diabetes, and immunosuppression are also well-established risks for both uncomplicated and complicated UTIs. Now, the clinical presentation of an uncomplicated lower UTI, or cystitis, usually includes a classic triad of symptoms: dysuria, which means painful urination, urinary frequency, and urinary urgency. Patients might also mention suprapubic pain or pressure, and sometimes their urine appears cloudy or has a strong odor. Gross hematuria can also occur. It's really crucial to make sure the patient doesn't have systemic symptoms like fever, chills, or flank pain, because those would suggest an upper tract infection, pyelonephritis, which definitely requires more aggressive management. In older adults, the presentation can be atypical. You might see new-onset incontinence, confusion, or lethargy as the only signs. So it's important to keep UTI high on your list of differentials for any elderly patient with an acute change in status. The primary diagnostic tool for a suspected uncomplicated UTI in a healthy, non-pregnant woman who has those classic symptoms is a urinalysis. A dipstick analysis showing positive leukocyte esterase, which indicates pyuria, and/or nitrites, which point to the presence of gram-negative bacteria like E. coli, is highly suggestive of a UTI. A microscopic examination confirming the presence of white blood cells and bacteria gives you even more evidence. For uncomplicated cystitis in a woman with a typical presentation, a urine culture is often not necessary, and you can start treatment empirically. However, a urine culture and sensitivity should always be done for men, pregnant women, patients with comorbidities, suspected pyelonephritis, or if there's treatment failure. First-line treatment for uncomplicated cystitis is all about eradicating the infection while minimizing collateral damage from broad-spectrum antibiotics. The preferred therapies include nitrofurantoin or macrobid for 5 days, trimethoprim sulfamethoxazole or Bactrim for 3 days, but only if local resistance rates are less than 20%, or fosfomycin as a single dose. Fluoroquinolones are no longer recommended as first-line agents for simple cystitis due to their high rates of resistance and the potential for significant side effects. Patients should be educated on supportive measures, such as increasing fluid intake, and they may be offered phenazopyridine or pyridium for 2 to 3 days to help manage the painful dysuria. Just make sure to warn them. It will turn their urine orange. Urinary incontinence, or UI, which is the involuntary leakage of urine, is actually a really prevalent and often underreported condition that can significantly impact a person's quality of life. The risk factors for UI vary depending on the type of incontinence involved. For stress incontinence, which is leakage that happens with effort or exertion, like coughing or sneezing, the primary risks include pregnancy, childbirth, obesity, and menopause, all of which can weaken the pelvic floor muscles. For urge incontinence, which is characterized by a sudden, intense urge to urinate followed by involuntary leakage, risk factors include advancing age, neurological conditions like stroke or Parkinson's disease, and bladder irritants such as caffeine and alcohol. Overflow incontinence, on the other hand, is often caused by bladder outlet obstruction from benign prostatic hyperplasia, or BPH, or impaired bladder contractility from diabetes. The clinical presentation is really key to differentiating the types of UI, and that's the first step in management. A thorough history is your most powerful tool. You should ask the patient to describe the circumstances of the leakage. Does it happen with a cough or laugh, which would suggest stress incontinence? Is it preceded by a sudden, overwhelming need to urinate, which points to urge incontinence? Or is there constant dribbling or a feeling of incomplete bladder emptying, which may indicate overflow incontinence? A bladder diary, where the patient records fluid intake, voiding times, and incontinence episodes for 2 to 3 days, can be super helpful in clarifying the pattern and severity. The physical exam should include a pelvic exam in women to assess for pelvic organ prolapse and atrophic changes, and a digital rectal exam in men to evaluate prostate size and tone. Diagnostic evaluation for urinary incontinence in the primary care setting is primarily clinical. A urinalysis should be performed on all patients to rule out a urinary tract infection or hematuria as a contributing factor. A post-void residual, or PVR volume measurement, which you can do with a bladder scanner or catheterization, is essential to rule out significant urinary retention. This is really the hallmark of overflow incontinence. A PVR greater than 150 to 200 milliliters is generally considered abnormal and suggests inadequate bladder emptying. For complex cases or when initial conservative treatments fail, referral to a urologist or urogynecologist for more advanced urodynamic testing may be warranted, but this isn't typically a first-line step for the family nurse practitioner. First-line treatment is tailored to the specific type of incontinence. For stress incontinence, the cornerstone of management is pelvic floor muscle exercises, commonly known as Kegels, along with lifestyle modifications like weight loss and managing constipation. For urge incontinence, bladder training, which includes timed voiding and urge suppression techniques, and avoidance of bladder irritants are the initial steps. If these behavioral therapies aren't enough, the first-line pharmacologic treatment for urge incontinence is an anticholinergic agent, such as oxybutynin, or a beta-3 adrenergic agonist, like mirabegron. Overflow incontinence requires treating the underlying cause, such as initiating an alpha blocker for BPH or teaching intermittent self-catheterization for a neurogenic bladder. A deep understanding of individual renal and genitourinary disorders is absolutely essential. But the real mark of an expert family nurse practitioner is being able to synthesize this knowledge. These conditions don't exist in a vacuum. They're often interconnected. For example, an untreated or inadequately treated urinary tract infection can directly lead to acute pyelonephritis. In turn, recurrent pyelonephritis can cause scarring and chronic kidney disease over time. Similarly, an obstructing kidney stone, or nephrolithiasis, is a primary cause of post-renal acute kidney injury. Recognizing these causal pathways is critical for both diagnosis and preventative care, which are core functions in primary care practice. This integrated perspective allows you to anticipate complications and manage patients holistically. For instance, consider the interplay between BPH, urinary tract infections, and acute kidney injury. An enlarged prostate can lead to incomplete bladder emptying and urinary stasis. This stagnant urine creates a favorable environment for bacterial growth, significantly increasing the risk of recurrent urinary tract infections in older men. If the obstruction becomes severe, it can cause bilateral hydronephrosis, leading to post-renal acute kidney injury. So, when an elderly male presents with a urinary tract infection, your assessment has to go beyond just prescribing an antibiotic. You also need to evaluate for underlying BPH as the root cause and assess renal function to ensure there's no concurrent obstructive uropathy. This kind of multi-layered assessment really demonstrates advanced clinical reasoning. The certification exam will frequently test your ability to connect concepts through complex case scenarios. You might see a patient with diabetes, hypertension, and taking an ACE inhibitor, now presenting with a rising creatinine level. Your job is to determine the most likely etiology of their acute kidney injury. Is it pre-renal, due to an intercurrent illness causing dehydration? Is it related to the ACE inhibitor affecting renal hemodynamics? Or is it a progression of diabetic nephropathy? You'll need to weigh the risk factors, analyze the provided lab values, and understand the mechanisms of action of their medications to arrive at the most plausible diagnosis and the safest next step in management. This synthesis of knowledge really extends to patient education and health promotion. When managing a patient with their first kidney stone, your role includes not only treating the acute episode, but also providing education on preventing future stones. This involves a discussion about hydration, dietary modifications, like reducing sodium and oxalate intake, and the importance of follow-up. Likewise, when managing incontinence, you're not just treating a symptom. You're addressing pelvic floor health, lifestyle factors, and potential underlying conditions. This comprehensive approach, which links acute treatment with long-term prevention, is the hallmark of high-quality primary care and a key domain tested on the family nurse practitioner exam. The ability to formulate a solid differential diagnosis is, honestly, one of the most critical skills for a family nurse practitioner, especially within the genitourinary and renal domains, where symptoms can be overlapping and nonspecific. When a patient presents with dysuria, your immediate thought might be a urinary tract infection. However, you really have to consider other possibilities. In a young sexually active female, urethritis caused by a sexually transmitted infection like chlamydia or gonorrhea must be on your differential. In a postmenopausal woman, atrophic vaginitis can cause significant dysuria. Interstitial cystitis, or painful bladder syndrome, is another important consideration for chronic dysuria without evidence of infection. Let's take a look at the presentation of flank pain. While acute pyelonephritis and nephrolithiasis are leading contenders, the differential is broad and includes potentially life-threatening conditions. Musculoskeletal strain of the back muscles can present similarly, but is usually reproducible with movement. In older patients with vascular risk factors, A dissecting or leaking abdominal aortic aneurysm can present with flank or back pain. Gynecological issues, such as an ovarian torsion or a ruptured ectopic pregnancy, can also refer pain to the flank. Herpes zoster or shingles can cause severe unilateral dermatomal pain in the flank area before the characteristic rash appears. A thorough history and physical exam are absolutely essential to narrow these possibilities. The certification exam will test your ability to differentiate between these conditions by providing subtle clues in the case vignette. Pay close attention to the patient's age, comorbidities, the acuity of onset, and associated symptoms. For example, the pain of a kidney stone is typically colicky and causes the patient to be restless, whereas the pain of peritonitis or pyelonephritis often causes the patient to lie very still. The presence of fever and systemic signs points toward an infectious process like pyelonephritis, while their absence makes a condition like a simple kidney stone more likely. Your ability to pick up on these nuances will guide you to the correct diagnosis and management plan. Ultimately, your diagnostic reasoning process should be systematic. Start with the patient's chief complaint and generate a list of potential causes, from the most common to the most life-threatening. Then, use the information from the history, physical exam, and initial diagnostic tests to support or refute each possibility. For example, if a patient has flank pain and fever, a urinalysis is a key step. If it shows pyuria and white blood cell casts, pyelonephritis becomes the leading diagnosis. If it shows significant hematuria, but no signs of infection, nephrolithiasis rises to the top of the list. This methodical approach ensures that you do not miss critical diagnoses and that your plan of care is safe and evidence-based. Our journey through the essential genitourinary and renal disorders has really equipped you with the foundational knowledge you need for success on your family nurse practitioner certification exam. We've systematically dissected acute kidney injury, acute pyelonephritis, nephrolithiasis, urinary tract infections, and urinary incontinence, focusing on the high-yield information you need to know, risk factors, presentation, diagnostics, and first-line management. The clinical pearls provided for each condition are designed to serve as memory aids, helping you quickly recall key distinctions during the high-pressure environment of the exam. Remember, the board exam is a test of entry-level competency, and a solid grasp of these common conditions is just non-negotiable. But honestly, the ultimate goal of this preparation goes far beyond passing a test. It's about integrating this knowledge into your daily clinical practice, so you can provide safe, effective, and compassionate care to your future patients. Your ability to recognize the subtle signs of pre-renal acute kidney injury in an elderly patient on diuretics, to differentiate cystitis from pyelonephritis, or to offer compassionate and practical solutions for a patient suffering from urinary incontinence. These are the things that will define your success as a provider. These are not just abstract concepts, but real-world scenarios you'll face regularly. Use this review as a springboard to build a deep and lasting understanding of these complex systems. As you finalize your studies, continue to think like a clinician. When you review a practice question, don't just select the right answer. Ask yourself why the other options are incorrect. This process of justification really reinforces your understanding of differential diagnoses and management pathways. Consider the what-ifs. What if this patient were pregnant? What if this patient had a sulfa allergy? This level of critical thinking will prepare you for the nuanced questions on the exam and for the complexities of real-world patient care, where clear-cut scenarios are the exception rather than the rule. Your preparation is an investment in your future and in the health of your community. Finally, approach your exam with the confidence that you have prepared diligently. You've built a strong clinical scaffold of knowledge regarding genitourinary and renal health. You can identify red flags, formulate a differential diagnosis, and initiate appropriate evidence-based treatment. This expertise is the cornerstone of safe primary care and the key to earning your certification. Walk into the testing center prepared to demonstrate your ability to think critically and act decisively. Your hard work will culminate in achieving your goal of becoming a board-certified family nurse practitioner, ready to meet the healthcare needs of your patients with skill and dedication.